excited to be here today, and we have an excellent agenda throughout this day for you planned. But our first panel will focus on the evolving landscape of acute care and hospital management, the hospital's role in the healthcare delivery system, and strategies for hospitals in this challenging environment. I have three very accomplished panelists coming up to join me. I'd like to ask Dr. Roger Mitchell, President and CEO of Howard University Hospital, Katie Eckert, Senior Vice President of Strategic Operations at Adventist Healthcare and new President of the Health Financial Management Association as of 12 days ago, and Nikki McCann, Vice President for Payer Provider Transformation at the Johns Hopkins Health System. So thank you all for joining me today. I want us to start out just a little bit informally. Please introduce yourselves and describe your journey into hospital leadership.
Can we adjust the chairs?
Yeah, we can adjust the chairs. I'm going to sit with you.
Lock. There we go. Down. Did you
going down?
You're going down. Come on, Roger. Come down to my level.
There it is.
Okay. Did you lock it?
You got a solid footing.
No. I went
There we go. I feel like Jimmy Fallon. You know, he's higher than everybody.
Good morning, everybody. Oh, y'all are still waking up. I'm a physician, so half our day is already done. So, it's been a whirlwind journey for me into healthcare leadership. My journey was, I'm a forensic pathologist and laboratory medicine doc, and that's kind of where I started. Was in government about over 20 years. Ended my career in D.C. as the deputy mayor for public safety and justice, and was the chief medical examiner for the city. Wanted to come over and deal with the work on the other side, do some prevention work. I thought the best way to prevent death was to serve and provide access. So got in as the chair of pathology, quickly rose to the chief medical officer for ambulatory care for Howard University, ran their quality and safety side for the ambulatory side, and then became president about 8 months ago in a transition. So really excited about being here, excited about the conversation. There's a lot of movement, both good and bad, in the healthcare sector in this country. So I'm looking to have a robust conversation. Thank you.
Good morning, everyone. Katie Eckert. I serve as the Senior Vice President for Strategic Operations for Adventist Healthcare. I've been there for a little over 2 years. And the way that I describe what my role and my team's role is we use data to drive strategy and performance improvement. My background, I'm a CPA by training. I'm a recovering hospital CFO and CFO for post-acute services for Bon Secours Mercy Health. I started my career at Bon Secours Baltimore Hospital, what is now Grace Medical Center. Worked my way up to be the interim CFO there. Went outside of state with our Bon Secours Mercy 14 hospital health system by working at our corporate office using data to drive strategic insights and operational improvements. You're seeing a theme here. I geek out on data. And I did a brief tour of duty at the Maryland Hospital Association, working on healthcare payment and leading strategic analytics. One of my hats that I wear for Adventist Healthcare and for the last 15 years in Maryland is being an in-house subject matter expert on all things HSCRC related. So it's a pleasure to be here with you this morning.
Hi, Nikki McCann, Vice President of Provider Payer at Johns Hopkins Health System. I am an attorney by background. I spent about a year as bond counsel. For anybody who doesn't know what that means, that's sort of issuing bonds to support water and sewer projects. That's what I did for about a year. And after a year of that, I thought, I liked waiting tables better than this. So I made the transition to government affairs. So I worked at a law firm in their government affairs office and found that I really wanted to bring sort of mission to the work that I was doing every day, and got a job working for the Maryland General Assembly. I was with the Department of Legislative Services, where I met my dear friend Erin. I think we started on the same day. And that is really where I started to work in health policy. I was committee counsel to the Appropriations Committee, and I had the Health and Human Services Subcommittee that I was staffed to. And that is where I found my passion for health policy. And it's interesting, I didn't even realize the state of afford mission, that intersection of healthcare and health policy. And so that is what my role at Hopkins is trying to bring that intersection between health policy, what is happening at the state, local, and government level, to healthcare delivery. And so I'm very fortunate to be at Hopkins for over 15 years now.
Great, and thank you all. And I think we'll just jump right into it. There are a couple questions here that I think people are going to be more excited about. And I'll start right off with a question for each of you. This is a question for all three. Can you discuss the impact of the changing federal policy landscape on hospital operations, patient care, or planning for the future? And where are the opportunities for growth, or what is keeping you up at night? So let's go the opposite way and start with Nikki.
So yes, the impact of the federal landscape is significant. I think it's really hard right now to plan for the future. It seems like you wake up every day and there's some new policy change, some change to healthcare delivery, to the federal landscape that is significantly impacts. So I would say it makes it significantly challenging to plan for the future, to think about operations. I mean, we have to really think about the changes to Medicaid eligibility, the increase of people, of the uninsured population. It is incredibly hard to plan in this ever-evolving landscape. What do you react to next, and how do you focus? And sort of, you always want to say, what's the most important thing for patient care? How do you remain focused on that? I wish that there was something right now I could cling to that got me excited. It's a little hard in this environment. I wish I had a better answer for that, other than, this sort of chaos that we're all experiencing brings people together. It creates unexpected collaboration, and I hope we see more and more of that.
Yeah, I completely agree. And I think there's two massive headwinds that we're looking at, really actually three, but on a federal level there's two, and the first is the cuts in funding. So cuts in funding for Medicaid are going to be pretty dramatic. Restrictions in Medicaid eligibility, which is then tied to funding, could be dramatic as well. Cuts in research and grants. And then also some of the changes around immigration. And so why that's important is we're looking at somewhere, between 15 and 20% are some of the estimates that we're looking at for nationally reductions in Medicaid reimbursement. And that's going to be pretty catastrophic to access in our communities, and being able to provide medically necessary care to those individuals. The other thing that we're watching with immigration, number one is access for those individuals in our community. So my health system serves one of the highest concentrations of undocumented patients in the country, in our Gaithersburg, Germantown area, and in White Oak. And so some of the changes around immigration are really impacting our ability to care for that community. And then the second thing that we have to factor in is our workforce. So the economists and the World Bank have put out some really great information watching this aging population in industrialized nations and where the baby boomers are going. And so the population in the top industrialized nations is aging faster than the workforce that's coming up and replacing them. And so you have this imbalance where we're going to have an older population and not have the workforce to fund Medicare, not have the workforce to take care of that aging population, not have the workforce to fill the jobs to drive the economy. And so with some of the changes around immigration and that pipeline of talent into the country, that is one of our key strategies that we've been working on that takes multiple years to put in place. We've set up international talent pipelines for nurses, techs, and providers, and now that's at risk. So those are some of, to paint some of the other themes around what Nikki was speaking to, are some of the operational ways that it's impacting us right now.
Yeah, and just to add to what my colleagues are saying, Howard University is a small community-based safety net teaching hospital. And so when we look at the federal landscape, obviously Medicaid, we're over 45% Medicaid, and if you add Medicare, and unsubsidized care or self-pay, then we're talking about 80% of the payment that's happening at Howard University Hospital is government or otherwise, right? So our private payer group is very, very small. So any movement on Medicaid reimbursement, any movement of individuals off Medicaid rolls is going to impact our bottom line, our ability to provide adequate care for our community. The big thing surrounding that is that we have disproportionate share, and you guys know DISH and DPP if you're doing this work. And in the District of Columbia, there's still an open DPP application. Whoa, right? If you're following the reconciliation bill, there's conversations on whether or not who's going to be grandfathered in surrounding directed payment, whether or not directed payment is going to be capped. Are you going to be able to get it if your application hasn't been approved? If, what's the percentage of tax, provider taxes is on the reconciliation bill. All of those things we're watching intently to see whether or not our DPP application is going to be approved. It really means several millions of dollars to Howard University Hospital to move from a disproportionate share hospital supplement to a directed payment program supplement. So that's a very tactical piece. The other piece that you might also be aware of is the FMAP, right? That Federal Medical Assistance Percentage construct. The good thing about this, here's the silver lining on this cloud, is that we thought that FMAP was going to be reduced, right, and under attack. It is nowhere in the reconciliation bill. Particularly, DC has a set FMAP at 70%, and it was at risk to go to 50% or below. That would have met about $40 million to my little small hospital, which is huge. So those types of things we're watching, and I think for us in Maryland and throughout the nation, we really need to watch the work requirement. That work requirement within the reconciliation bill is a big deal. It looks like that is going to pass, and that is going to pull a lot of people off of the rolls. And is going to create an environment, particularly in my hospital, where that's not going to stop individuals from seeking care. It'll just whether or not they have the insurance to be able to pay for that care. So a lot of the things that we're doing for the future, and speaking to what the future looks like, is we're working with our MCOs, we're working with our FQHCs, we're working with our Department of Healthcare Finance to make sure that those that are going to be moved off to a basic healthcare plan, that we identify who they are and help them get onto that plan, right? Help them navigate this process. Those that are on work requirements, helping them, if it's every 6 months you got to prove that you're working or seeking work. How does the hospital system or the healthcare system, and this may be something that you can think about, how does your system make sure that people aren't just falling off through to attrition? Because that's where the calculus comes in, is that those individuals that are leaving from attrition, those are counted in the discounted costs. And the more people we can not lose to attrition, the better our healthcare delivery is going to be for that population.
Thank you. Thank you all so much. And I love this idea that out of chaos comes collaboration, and we heard a lot of that from all three of your responses. Dr. Mitchell and Nikki, Dr. Mitchell, you talked about Howard being a teaching hospital. And Nikki, we know that Johns Hopkins is a huge academic medical center. How do you see the role of academic medical centers evolving over the next decade or even over the next 5 years, and particularly in urban settings like Baltimore and DC? And let's start with Dr. Mitchell since we started on this end last time.
Sure. I mean, that's probably where the greatest growth can be when we're talking about providing the type of education to students that are going into healthcare. And it's almost cliche. We talk about artificial intelligence, right? AI and technology, and utilizing technology as part of your diagnostic algorithm, part of pathology. We're building out digital artificial intelligence supported digital pathology in the Adventist and Howard system. And so that's the future of really ensuring that our medical students have a curriculum that centers technology, centers the patient, but also centers a collaborative approach to the education, and ensuring that our medical students are becoming more clinical earlier. And the curriculum reform that's sweeping the country is that, ensuring that our students are learning in real time and doing applied medicine. One thing that is a risk, however, is this notion that you can create a workforce of physicians that is not diverse. Somehow you can have a workforce that doesn't look like the communities that it's here to serve, and I think that's a huge risk. There's a lot of movement. LCME, the Liaison Committee on Medical Education, just revoked their DEI a requirement to be a accredited medical school, and so that's a problem. ACGME this past weekend paused it. They didn't revoke it, but they paused their requirement, citing that they did not want to shut down any programs because of state law that goes against DEI. So when there's an attack on diversity in medical education, then there's a creation of an imbalance that does not allow for women, does not allow for LGBTQ, and may not allow for black and brown students to have an equal playing field. So I say that because those types of risks we need to make sure that we look at and ensure that we make sure that our medical students have an opportunity to treat and work in every single community.
So I think there's two answers to your question, Aaron. There's how can we grow and how should we grow? And I think today's reimbursement climate, the changes that are happening at the federal level will dramatically impact how we can grow, which is not necessarily sort of in the same direction and how we should grow. You know, as an academic medical center in Baltimore City, there are many programs we've had focused on making sure that clinicians are trained in serving a disparate population. Baltimore City is, I think, about 44% Medicaid compared to the statewide average of 25%. And yet, the Johns Hopkins Hospital operates at a functional capacity of 111%. So what I mean by that is when you look at the number of patients who are in the emergency department, the number of patients who are actually in a bed, and those patients in the emergency department waiting for a bed, the patients in a bed, and then the transfers that we have accepted, those highly complex transfers that come from all over the region, that puts us at a functional capacity of 111%. The Johns Hopkins Hospital has more licensed beds than it has physical beds. The way that the state calculates licensed beds, you get its average daily census. So since our census runs so high, that's why we have more licensed beds than physical beds. When you look at the aging population, every statistic, all data points to the increased demand for tertiary quaternary care. As people get older, they're going to have more complex conditions, length of stay is increasing, complexity of care is increasing, and so there is more demand for our beds, and so without the ability to expand our capacity, that will continue to put constraint on our ability to meet our research, teaching, and clinical mission. And then I didn't even touch on the research aspect of it, but you know, Johns Hopkins is one of the largest research organizations in the country. Research is core to our mission, and yet we are seeing sort of attack on this notion of research at this point in time. And so I think the questions we will have to ask is what are the resources that we can find to allow us to continue that core research mission under a climate that's not supporting it, and so you don't want to see that decimated in hopes that in the future that can recover. So I think it's very different between how we should grow and how we can grow in this climate.
That's great. And you know, AI and new technology has come up a couple times in our conversation already. And Katie, you and I have spent a lot of time over the past couple weeks talking about new technology and AI. So what do you see as the role for technology and innovation, including AI, in transforming healthcare? And I know, Katie, you've been thinking about this a lot.
Yeah, so particularly in my role at Adventist, this is a big part of what I'm trying to do thought leadership around with my colleagues. And I think we are in the middle, not in the middle, I think we are in, and I don't know where we are in it, we are in a radical paradigm shift. And I don't think that we have begun to understand what that looks like. And I say that because like I'm actually a computer programmer, a comp sci major by training before I switched over to finance. And so I geek out on some of the technology stuff, and I think I know enough to be dangerous. And I was at an AI retreat last week that one of our business partners hosted for us, and it absolutely shattered my framework for thinking about AI and the impact on healthcare, on our economy, on everything. And my takeaway walking away from that was, I'm not thinking about this correctly. I don't understand where this curve is going to go, and it's going to impact everything. So we think about our EMR, we might not have an EMR in the future. It might be something completely different. I don't even know the words to describe what it is, but we have ambient listening already being used in rooms by our providers to document what's happening. That's completely transforming the role of the provider, I think in a good way, because it's taking that administrative burden off of our providers, so that's really exciting. We have a major pinch point in physicians coming through the pipeline. And so if we have to figure out how to leverage those providers to be able to meet the need of the population, so AI could be really transformative. Roger mentioned what we're doing with AI in our labs, and we're doing it with imaging, of having AI go alongside the provider and read the diagnostics and kind of be that second set of eyes. But there's a whole host of ethical things that come up with that as well. You know, if we're holding imaging scans going back 10, 15, 20 years, you know, what is your ethical obligation to run that AI over those scans to try to find things? The workforce is a big one, and I've been watching some of the for-profit companies in the financial sector and the technology sector as well. I was at this AI retreat last week, and one of the things that really struck me is we've been talking about AI replacing the workforce. It's happening now. And a lot of companies with the tariffs, because we had a topic about tariffs and AI, and I was like, how are tariffs and AI related? Like, I don't get this. Well, they're related because there's an assumption that US companies are going to start to onshore their workforce and their production and manufacturing. No, what they're doing is they're leaning into AI instead. So I don't think we're going to see these jobs created in the US, these jobs created in Maryland. Remember, Maryland has the highest concentration of federal workers and contractors in the country. And so with all of these layoffs happening, I'm not seeing the companies that could potentially be replacing and hiring. What I'm seeing is that they're holding on hiring, and they're telling their teams figure it out with AI. And so that is happening right now.
Thank you all. And so let's make a little bit of a pivot. We've talked a little bit around value-based care, but here in Maryland, we know value-based care. We've been in this space for a long time. So my question is for Nikki and Katie. What have we learned over the last decade operating under Maryland's total cost of care model, and what would you like to see as we transition to a HEAD or any subsequent model? So let's start with Nikki.
First, show of hands, don't be shy. How many people know what the Maryland model is? Okay. I'm going to give, for those who don't, a very quick elevator speech on what is the Maryland model. As it exists today, there are two foundational aspects of the Maryland model. The first is rate setting. This means that every payer, regardless of your insurance status, pays the same rate for the same services at the same hospital. So if you walk into Johns Hopkins Hospital, you have Medicaid, you have commercial, you have Medicare, everybody pays the same rate. You don't have that cost shift between government payers and commercial payers. And that's been in place since the 1970s. The second aspect of it, which came to the landscape in 2014, is global budgets. Global budgets is a capped revenue. Some people refer to it as capitation. It is not capitation. With capitation, more patients equals more money. It is a capped revenue model. So whatever a hospital's revenue base was in 2014, it forever remains the same, regardless of the number of patients you see, with modest adjustments for inflation updates, changes in market dynamics, changes in your population. But these are very modest adjustments. And so what is intended to be is a system that really segregates that incentive that exists in healthcare where volume drives revenue. It's intended to sever that tie. So that is, at the highest level, it's Maryland model. I'm sure there's people in this room who are way more expert in it than I am, but if anybody didn't know, that's an overview. I will tell you, and I am speaking from my perspective as somebody who works at a hospital, who's meeting with frontline staff, who's meeting with leaders, who are trying to figure out how to work within the constraints of this model, particularly as we're seeing an increased demand for care with the aging population. When this model first started, I was really excited about it. I was really excited of the prospect and the vision and the thoughts of making investments in population and community health that will, over time, make people healthier and decrease the demand for hospital-based care. That had tremendous promise, and that was exciting, and I think there was a lot of enthusiasm for that vision, while at the same time there was hospital stability. A hospital's revenue would remain the same as you made these transitions. But I would say in reality that is really hard work, and it takes years to see the outcome of those investments. And until everybody is investing in the same way, in the same initiatives, you're not gonna see any significant changes in the population health, changes in hospital utilization. And so I guess what I would say, the challenges that we are experiencing is that the model to date has really been focused on decreased utilization, and it hasn't had that corresponding focus on population health, improving the lives of the community. So I still think there's tremendous promise in the model. I still think there's opportunity there, but I think in Maryland, we went too hard too fast. So I just want to be clear, 98% of hospital revenue is under this capped revenue constraint. I think that if we had instead started slower and we were deliberate and we said, okay, on a statewide basis, we're gonna focus on diabetes, or we're gonna focus on congestive heart failure, and you had every hospital in the state and every local health department and every MCO focused on those initiatives, that probably was the promise to make a difference, and then we could pull out what are the lessons learned, what was effective, what interventions worked, what didn't work, and then how do we translate that to the next chronic disease, the next social determinant of health. So I guess what I'd like to see is a step back and a recognition that maybe intense utilization decline isn't the direction we should go in, and instead how do we focus on chronic conditions as a state and move the needle there. So I still believe in the promise of the model, but I don't think we're where we need to be today. Right now, I have concerns that if we continue under this current state, there will be access to care issues. And so that's my vision, that's my perspective.
Katie?
Thanks, Nikki, and to build on what Nikki said, the promise, the intent, the goals of what we were trying to do 10 years ago when we decided to try to experiment with global budgets were extremely well-intentioned. But I think hindsight's 2020, and we've learned some lessons at this point that are creating barriers to access for medically necessary care. And so global budgets, you asked for corrections, what we'd like to see improved. what Nikki said was correct. The global budgets were set back based off of 2013 patient care patterns utilization, and that has remained largely materially unchanged since then. Yet we all know that the population has moved dramatically throughout the state since then. You look at what's happening during COVID and post-COVID with some of the shifts in the population. And so effectively what we did is we locked in the healthcare infrastructure for hospitals back in 2013. We've made some small changes since then, but we were very focused on policies, payment policies to handle reduction in volume. But we never created robust policies to handle situations where there might be increases in volume. And so now we're left in a situation 10 years in where the infrastructure that existed back in 2013 is locking in historical inequities. You know, I look at Prince George's County, they have historically had a 40% or higher out-migration rate because they never had the healthcare infrastructure in the county to begin with. And so locking in that healthcare infrastructure and not allowing the funds to follow the patients to areas that are rapidly growing and aging, like in Montgomery County, in Frederick, and Howard County on the Eastern Shore, that creates barriers to access and care. And so a lot of our policies were focused on a statewide average, and that worked out of the gates. But when you look underneath the hood and look at it on a regional basis, that's where we have issues. So we might have enough hospital beds in the entire state of Maryland. We might have enough hospital global budgets to fund access to medically necessary care across the entire state of Maryland. But it's not in the right places now when we look at this on a regional basis. And so, and I can speak only for our service area, in our areas of the state that we serve, we are seeing barriers to access to medically necessary care because the global budgets were fixed and we haven't developed policy to handle situations of rapid growth. I'll give you an example. At White Oak Medical Center, they've had a census that's grown 130% since 2017. And so that's kind of an extreme outlier situation that we would need policy to make sure that we're funding adequate access for those patients.
Great, and thank you. And I was told to reserve the last 10 minutes for audience questions. I don't know if we have someone out there with a mic. Okay, great. Let's go right here. Are we walking around with the mic or? Yeah, I can. Okay, right up here.
James, you promised no questions.
I know, seriously.
I promised hard questions. I've been thinking all night about this. So I'm fascinated about the concept of collaboration and collaboration across the state and the hospitals and the health plans and the county health departments. What's working really well right now in that collaboration? What's not working? And how do we double down on the things that are working to get more collaboration?
So for Howard, I don't know if this, can you guys see? Yeah, there you go. For Howard, what's really working well is the collaborations that we have with our FQHCs. You know, as really a specialty clinic service and a hospital, we rely heavily on primary care, as you would imagine, for all health systems, for the movement from primary care to specialty care. And so those relationships are really working well. We've developed a technology bridge between those organizations for referral, which is very easy to use so that they can refer into Howard University's practice. So those collaborations are working well. Collaborations with the MCOs for our value-based care is quite frankly in its toddler phase. We need to improve that, but there's room for that for those MCOs and that value-based care construct to improve, and those collaborations are working well. One thing in your question, James, that you may have inadvertently left out is, how does business come into this, right? So we're developing relationships with our Chamber of Commerce and those small businesses that need healthcare delivery for their employees, and creating an opportunity where the employees and these particular small businesses can come directly to care and create collaboration for the care of their individuals, whether or not they're actually providing insurance or not. So they may be on Medicaid or some type of supplement because of the level of income that they have. But then they also have access to care that the small business is working to help their employees. And then lastly, big business. I think it's very important as we understand that the supplement that's happening to hospitals is decreasing. How do big business in a community come in relationship with their hospitals, with their healthcare delivery systems, particularly ones like mine that are safety net, to ensure that charity care is supported in a way that the hospital can continue that charity care.
And James, I'd like to give a specific example, which is there was funding that was made available through the Health Services Cost Review Commission, the state agency that oversees Maryland's unique reimbursement hospital model, that allowed for investments in behavioral health. And so for the specific example is, as I know that there were many statewide initiatives, but in sort of the central Baltimore region, you had 3 counties, 17 hospitals, local behavioral health authorities come together through this funding available made to the HSCRC to invest in behavioral health crisis services. So we worked with Behavioral Health Systems Baltimore to be sort of the administrator, the lead of this program, to expand mobile crisis teams across those 3 jurisdictions, to create standardization across those 3 jurisdictions about what a mobile crisis team meant. I mean, before this initiative, in one county it could be police, in another county it could be a trained mental health professional and a peer. So with standardization of that, it was creating a robust call center, sort of care traffic control, it was what it gets referred to, and then investing in community behavioral health providers to make same-day appointments accessible. Now, what we have seen across this region is a decrease in inpatient hospital utilization associated with behavioral health and increase in emergency department demand for behavioral health services. I don't think we can say exactly that, oh, this initiative resulted in this outcome. There's too many other factors. We know that telehealth and behavioral health is a big pickup. But I do think that multi-hospital, multi-state collaboration, multi-county collaboration really did, I do think it contributes to that decreased utilization for hospital-based behavioral health services. And to me, that level of collaboration could really serve as a model to address other chronic diseases or other social determinant of health issues. So my dream, my vision is that we would have that same structure, that same concept in Baltimore City, where you have huge health disparities. As I said earlier, over 44% of the population's on Medicaid. How can you create that infrastructure, that level of collaboration to tackle both chronic disease and large social determinant of health issues? I'd love to see more of that kind of collaboration being done. I think that was a great start, and I think I saw Adrian Brainstein, so shout out to our friends at Behavioral Health Systems Baltimore on that. And just to be clear, of the funding that was made available for that, all the 17 participating hospitals put that funding out into the community. I think that is unprecedented. No hospital retained any revenue for their own support of this program or anything like that. All of those dollars went out into the community.
Are there any other audience questions?
Can I add to that
Yeah, of course.
while they're thinking of questions? It just reminded me today at Howard, we're launching our Sickle Cell Day Clinic. And that Sickle Cell Day Clinic is funded by DC Health, but in collaboration with several MCOs, where it's intended to be an infusion and pain center for those that are in sickle cell crisis, as well as both walk-in as well as appointment, so that individuals that would normally come into the emergency department, not just in Howard's emergency department, but in other emergency departments in the District of Columbia, instead of going there, they come to this day clinic, receive 7-8 hours worth of care, and then they leave. And if they need to come back the next day, then they can. And it really does what Nikki just spoke about, where it really decants the need for hospital-based services, and move those into an outpatient space that is going to be more caring and providing better care than coming into an emergency department, then being admitted for your infusion and pain care, and then leaving, and then actually being readmitted within 30 days into the emergency department for same level of kind of pain control for sickle cell. So those are the types of collaborations, wherever they exist, are really good for healthcare delivery, whether it's Maryland or the District of Columbia.
That's great. And are there any other questions? Because I'm getting word that we have about a minute left, and I can say that 45 minutes is not enough time to talk to the three of you. I could talk to the three of you for hours, and I want to thank you for joining us today. Are there any last words you want to say before we get played off the stage here and the music starts telling us to get up and move our butts? Any final parting thoughts? Hang in there.
So I was thinking, because I've had this comment to me a couple times, like, you're the pessimist, Katie. I was like, well, no, I'm a realist. Once we accept we have a problem, then we can start to solve the problem. And so I am excited to work with really smart people to solve really complex problems, and to try to figure out how to ensure access to care in our communities, and to sustain our mission.
I mean, this is the beginning plenary, right? And there's a full day of a conversation that smart people in this room are going to try to solve problems, get educated, and so lean into one another. There's no one coming to save anybody. So
We are the ones we've been waiting for.
right, so you're in this room because you're going to come up with solutions, real solutions, that improve the healthcare delivery, quite frankly, not just in Maryland, but Maryland has the opportunity to be a model for the country. And so, lean into that in a real way, and be successful today. So good luck.
All right, okay, now I need to be a little more eloquent than hang in there, okay? After those two responses. And what I would say, and this is a specific example, but I was at the Johns Hopkins Hospital. I was getting coffee. It was in my normal work day. And there was this woman in front of me who was crying. And I thought, I should probably ask her if she was okay. And so I touched her on the shoulder, and I said, are you okay? And she said, no, my husband was just diagnosed with cancer. And I am not clinical, right? So I am not reminded on a daily basis that we sort of are touching people's lives. And so it's an important reminder that as healthcare institutions, we are often touching people on the best and the worst days of their life, right? The birth of a baby, the loss of a loved one, the diagnosis of a condition, the announcement of a remission, like the best and worst days of people's lives. And that is an honor, that is sacred, and that is something that we should all hold dear. And just remember that in the healthcare space, for many of us who really don't have that daily patient interaction, to remember that there is an individual behind the work that we do, and that there is someone who's really relying on us. So give it your best and do what we can to really help those individuals, help those patients.
Thank you. I think that's a great place to end, and I just want to say thank you all for joining us this morning and being our opening plenary, and I hope that this sets the day off. I think that this will set the day off in a good place. So can I get a round of applause for our